There's an interesting movement slash project. I don't know. I think it matters around pain. We have a pain doc here. Dr. Tania Di Renna is here, and pain doc. What's a pain doctor, Tanya?
So I specialize in helping people manage their pain, either with injections or medications, or referring them to specialists like physical therapists and psychologists. And we have a lot of work.
Yeah, I bet there's a lot. There's a lot of general pain. I think that people go through, and pain is one of those sneaky things that it becomes so chronically not aware in your life for some people that it just kind of bubbles in the background. But relief from pain, oh, that can be eye opening too. Just like when you step on something sharp and it gets your attention, relief from pain can also get your attention. Yeah.
That's right. Well, Shane, it's a huge problem. I mean, one in five Canadians have chronic pain, so it's a big deal. And as the population ages, that number is going to go up, right? And we know the baby boomers are getting older, and so we're going to see that number get higher to probably one in four. So if you don't know about it now, you might in a couple of years or so.
Dr. Tania Di Renna, lots of fancy education letters, associate professor at the University of Toronto, Department of Anesthesiology and Pain Medicine. And so this has been your world. Like this is literally everything that you do. Why did you choose pain?
So I love this job. I actually specifically focus on pain in women. And the way I got into managing pain in women is because no one else is doing it. And it was quite sad. So I'm the medical director of a program called TAPME, which is the Toronto Academic Pain Medicine Institute. And 70% of the patients that flow through our central triage, which sees about 7,000 referrals a year, are women. And we didn't have a lot of a home for a lot of women with pelvic pain. And so we couldn't say no. I mean, we are one of the biggest pain centers in Canada. And so where would we send them if we said no? So we had to create a pelvic pain program, and that's the focus of what I do every week. This isn't something that's unusual. This happens a lot. There's not a lot of female specific care for pain conditions.
That's interesting. Why is that though? Like, is it because of the programs aren't there? People don't know about them. It's just underrepresented. People don't report it. I mean, maybe a little of all of the above.
Yeah, it is a little bit of all of the above. So women's pain is really underestimated and usually misdiagnosed, right? So, according to recent research from the Shoppers Foundation for Women's Health, 3 out of 4 women have felt that their symptoms weren't serious enough to go seek help. And so 80% of women actually know someone whose condition could have been caught earlier if those symptoms were better understood. So a lot of women don't even go seek help for certain issues. I've been studying and treating women's health for years, and things just show up differently in women. Symptoms show up differently, and it's not everything that we were taught in medical school. A lot of the symptoms for certain diseases were studied in men. Take heart attacks, for instance, chest pain, jaw pain, arm pain. That's a pretty male dominant pain pattern for cardiac arrest. And so women are 5 times more likely to be, released from the emergency room while having a heart attack. That was a study done a few years ago.
That's crazy to think. Plus, y'all are tougher.
Well, we have more to deal with in terms of reproductive health, right? Reproductive systems are different. We're not tougher. I think we're just different. And I think the research and education should just focus on that. It's just focus on including us. In 1977, between 77 and the 90s, we were actually excluded from most pain research or most research at all, most clinical research, because, the thought was that it was protective. The thalidomide scare with deformities in pregnant women really scared people and excluded us from research. And it basically led to some lazy science where everything was done on males and male animals and then just applied to females, and we're vastly different.
So you said women and say misdiagnosed or walk out with a heart attack. That part's interesting to me. How is it? To me, that would seem obvious, wouldn't it? I mean, I'm not even a doctor, But how is that kind of stuff, that magnitude of health conditions, misdiagnosed?
Well, that's just one example, Shane. Like women's pain is often treated like an emotion. We really pathologize it, right? We say women are anxious when we're really saying like they're unwell. We call them dramatic when we should be saying, this woman is suffering. We often treat pain as an emotion and not as biology. There's examples of women having to wait longer than men for pain relief in the emergency room. We're more likely to be given sedatives or anxiolytics, medications for anxiety, rather than pain meds. We're often labeled as our symptoms are often labeled as stress or psychological rather than, maybe a physiological reason for it. So this really shapes a biased diagnostic pathway for a lot of women.
I hear that because I hear that in my language study that, we often recklessly use words like anxiety. Yeah, I know that when I go in the doctor, I'll always say like, look, I don't understand what words I'm supposed to use. This is what I know to use. Please let me know what this is actually called or what we're going through. And we often, as a society, use words like, my anxiety, for example, when it's not anxiety. It's become this sort of it word. And that to me takes away from people who truly are anxious, right? As opposed to people who are worried or experiencing stress and all of those things. And then I would imagine as a society that just spills over to speaking differently, listening differently, not knowing the definitions of these words and how we're supposed to use them. And then you have people that are just trying to get help because they truly are in pain. And then they can't because the people around them aren't listening the same way. Is that a fair ball?
That's an excellent comment. I love that you said that. There's this research in pain called pain catastrophizing, where people ruminate, magnify, and feel helpless. It's like a psychological construct around pain. And women do it more. And of course, we do it more. Wouldn't you if you were being sent home from the emerge in the middle of having a heart attack? Like, yeah, we have to be kind of catastrophic and maybe dramatic. But that's because we're unwell, right? And no one's listening to the symptomatology. And some people don't even, like the Shoppers Drug Mart study showed, that they don't even go seek help.
Well, how do they advocate for the help then? I mean, it's one thing to ask for help, and it's one thing to ask for help and have it not get listened to. Both matter.
Yes. Yeah, that's an important question. I think it really boils down to a few things. In medicine and academia, it's research, right? Research and training. So we need women doing more research. We need more female researchers to ask the right questions. We need more training about gender differences and gender biases for healthcare professionals. We need to teach women how to advocate for themselves. Bring an advocate when you go see your doc. Don't be mean about it, but just bring a second set of ears to ask questions. Track your symptoms, bring it back up, write them out clearly. Say, I don't know why I'm having this. Can you possibly explain what's going on here? Be a part of research. There's lots of research projects going on. Ask to be a part of research. Ask to teach trainees. A lot of patients that I see, I work in an academic center, don't want trainees as part of their healthcare team. And I think that's the saddest thing you could do, because you're actually doing a disservice to yourself and all other women. Trainees need to be trained how to listen and how to speak to women and listen to what the questions are being asked. The language, as you mentioned, what do we say when we mean we're having pain, right? We have the sense of impending doom when we're having a heart attack. Like, listen to the language. So I think it really boils down, Shane, to research and training. And, research requires dollars and training requires dollars. And so, I'm really excited to shine a light on Shoppers Foundation. They committed $50 million by 2026 into women's health and research projects. Shoppers, along with Women's Health Collective Canada, they funded 500 women's health research projects, and we need to ask those questions. And so I think the key to, Shane, to women getting better is not just advocating for yourself, but also advocating for better research and better training, and funding that.
Well, it is fascinating, and I'm sure in the world of Dr. Google, this is not going to get any better with Dr. AI. So keep that, all of that, plus don't self-diagnose, go to the professionals. That's probably an important one just for the sake of being thorough. Tania, this is great. I really appreciate this. I did not know any of this. And so this is all new to me today. And all of this you have taught me. So thank you.
No problem, Shane. And listen, in learning about each other, men and women get better together. We get healthier together. We can, this is not just about taking care of women, but if we're healthy, we get to take better care of you, and you get to take better care of us. So I think that's where it lies. It's not, we just want to be equal.
Yeah, and that's it. And it should be a dance, not a wrestling match. And this is the best, beautiful part of it. Dr. Tania Di Renna, thank you.
Thank you. Thanks, Shane. Thanks for having us.